But then we look at our own data and we say, oh, but wait, at all of our other practices, we only actually do 350, right? Then there's, we've got to find a way to balance the top end potential and what we actually do on the ground level. And I think probably taking a combination of both gives us that, ceiling to reach for, but then also say, how are we doing actually implementing the testing with our build data, and it gives us some KPIs to watch along the way in terms of what it should be, could be, and what it is. And so, I didn't necessarily do it on build, but had I started over, I would have probably said this is our realistic now. We've implemented it, gangbuster, just because we're big into functional testing, and you'll love this in preparation for the talk.
Hello and welcome to the Crystal Podcast on iCode Media. Today I had a great conversation with Dr. Brad Grant. We discussed ERG and practical implementation of ERG into a clinical practice. We discussed patient selection, so what kinds of patients we want to take care of. We discussed how do we fit that technology into our practice flow. We discussed the benefits of it in terms of clinical decision making, both in changing our clinical decision making or reinforcing the decision making we have already had. Please enjoy our conversation. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local MacuHealth representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to MacuHealth.com and use the coupon code PODCAST2024 at checkout for special discounts. So, Brad, tell me a little bit about, just to give my perspective, tell me a little bit about your practice, where your practice is located, what your town's like.
Yeah. So we have, where I do most of the clinical coverage is in Bloomington, Illinois. It's a 9OD 5MD practice, so it's a large group, but we actually have 10 locations altogether. I own different entities, so I have 5 private practices and then retail locations as well. So we're in Illinois and Wisconsin. So it's a little bit of everything. We actually have ODMD shared partnership, and then I also have private practices that I own 75% of that I don't actually see patients at, but we have associate ODs there. We even have some retail locations that are telehealth only, where we have office in Wisconsin and a doctor in Texas, seeing those patients. So we have a mix of everything, and so it's from an integration of testing standpoint, we've had to implement it in offices where I'm there seeing the patient, working with the staff, as well as offices where I've never been there seeing a single patient. So
so I was doing a talk to some students last night or yesterday afternoon, and we were talking about telehealth was primarily the talk and the discussion.
Mm-hmm.
And so my primary point of telehealth, my entry point was within the pandemic. And so really we all sort of expanded into the pandemic, and I look at telehealth still today as an extension of my existing practice to allow me to access my patients, or vice versa, my patients to access me. And it gives me a nice intermediate barrier where before, I always say this, but before the pandemic, it was either I get to take call and I have to triage it via phone call, or I have to come into the office at all hours, right? There's no in between. And telehealth is a really nice intermediary for that. And then we started talking about what you're doing with telehealth, from the sounds of it, where there's a doctor in a completely different state or physical location, and then the practice is running very similar to I'll call it a because I think we mess up terms. I'm just going to call comprehensive care, where
Primary
you're basically
care.
providing, we won't get into semantics,
Okay.
but the reality is you're providing comprehensive exams, right? Mm-hmm. Comprehensive exams from a remote location. And how can you integrate that into being able to deliver the full package, the full suite of comprehensive care? And I think it's really interesting because my guess is that either you're at those locations, you're calling them retail locations, you probably have a pretty good protocol set up where if something's abnormal, whether that's from a fundus photography, a slit lamp video or image, a OCT, maybe even an ERG, there's either going to be a doctor that's going to be physically present at that location at some point in the future, or you have coordinated referral systems back into your other practices. Tell me a little bit about that, because I think that's interesting to a lot of our younger listeners, as well as, we've got a lot of practices in the rural part of the country that these types of opportunities are probably the only way that you're going to continue, or likely the main way that we'll be able to continue to deliver care, quality care in those communities, but also not skimp on the complexity and the comprehensiveness of care. So tell me about that.
So I would say the largest motivation is just the reality of the statistics of providers versus patients, right? 347 million individuals in America, and not nearly enough primary eye care providers to see them. And so in one of the locations in Eau Claire, Wisconsin, purely a lack of doctors in the area, right? And so we don't have a private practice in Eau Claire, and so for that we've set up, the staff knows it's on the ground level. When the doctor wants to refer for any kind of retinal pathology, this is the office that we send to. If it's cataracts, it's a different office. So we've coordinated those referrals with on the ground, for the most part, MD providers, because we're usually referring out if it's surgical based or needing some kind of procedure. In Madison, Wisconsin, we actually have a retail location that is telehealth only, but 20 miles away, we have a private practice. And so in those instances, it's a very easy referral. Look, if this individual has something that's above and beyond what you feel comfortable managing from a remote care standpoint, then that gets sent to our live doctor 20 minutes away. And if a patient for some reason doesn't want to go there, then we also have some even more local MD referrals that we might go to within 5 minutes. But we have that as a safety net for all of those locations that operate in that way, for sure.
Do you have any providers that actually so in those remote locations, that on occasion they'll have somebody there physically, where you actually like once a week or once a month or once every couple of weeks, where they're like, okay, we can still hold on to these patients, we don't have to send them out right away, but if we need to do gonioscopy or other procedure-based treatments, we can do those things when we're physically there?
We don't in those two, and just based I mean, obviously that would be the perfect scenario, but I think the limiting factor for a lot of us in multiple location type ownership practices is doctor availability, and so
Yep.
and so we don't have the resource to necessarily have them live, so that we refer. And in fairness, right? Are we trying to manage the same conditions at those locations that I would when I see patients live? No, right? We're not trying to manage glaucoma remotely. We're trying to at least be able to provide refractive care, comprehensive care, to where we can diagnose and appropriately send those individuals out for the more higher level care that they need. But it serves as, I think it all kind of depends on how you see it, right? If you see it as two different, supposedly equal things, right? Is it better live or virtual? Well, it's better live, right? It's never going to be. But if you're talking about this patient has no care at all,
right,
versus
totally right.
a very robust filtering process that can then send them to the right area, or possibly just say, you're -6, or let's fit you in contacts and there you go. It's not that one is better than the other. It's that it's necessary based on the fact that we don't have enough providers to serve the needs of all the patients that are out there. And, there has to be some kind of solution, and this is part of it.
Yeah, I think, I don't know if it's gotten a bad rap or it's gotten a better rap. I think still it generally has a little bit of a skeptical, I won't say negative, but there's sort of a connotation to remote care that it's less. I don't think it has to be. And I also, it's got me really intrigued. Like, I've got a big family. I don't want to travel a lot, and so that's why I haven't explored this. But we have locations in Nebraska where there's a lot of patients. Like, there's a lot of people that live in these towns, and the doctor that's there is 75 years old and he wants to leave, but he's got an obligation to his community, and he can't find anybody that wants to practice there. You're like,
right.
And by the way, the draw is 16,000 extra people in addition. It's like,
right.
you're sitting on a population of patients that need care. And so it's like, and then I start thinking, I'm like, well, I could do this. Like, we could figure out a way that we, can deliver remote care. I love to fly, so give me an excuse to fly out there once every couple of weeks and actually see patients. But I mean, I don't have the time. I don't have the bandwidth. But my point is that it's really intriguing to me, and it doesn't have. I don't believe in the technology that we have today. I don't believe it has to be inferior care. Now, that doesn't mean it isn't in some cases, but I will say that it doesn't have to be. And so I think that comes down to the providers. It comes down to the physician.
Yeah, I think, from two different perspectives. One, if we're just putting on a business hat, right? If we put on business owner hat, non-clinical hat, right? There's a tremendous opportunity in those areas they need care from somebody, right? We should be the, owners of that care if we can figure out a way to deliver it from a business, model standpoint. And two, we'll talk about this a little bit more in the ERG. We've built, it doesn't have to be an exterior clinic, but when you get so busy in your regular clinic that you can't see new patients, right? You have to think of a different system to be able to see everybody. And so we've gotten to the point where we do a lot of testing only visits. And as you start implementing technology, you think, oh gosh, I have an ERG, I have an OCT, I have a visual field, I have acuities and pressures. I mean, am I really delivering that much more value by seeing what shoes the patient's wearing, right? I have the information that I need to make a clinical decision. You can provide good care if you have the right technology in place that gives you that data. I think we're going to see it growing.
Totally agree. And I think, that's a good segue into, we're talking, you and I had connected originally. I would love to actually take another kind of a little bit more depth. Maybe we even schedule another episode where we talk about telehealth specifically, because I think it's interesting. But I did want you to talk about ERG. So we developed a course on iCode, Practice Performance Partners, that dives into the practical implementation of ERG. And the reason I reached out to you was mainly so that you could pick apart that course and give me your perspective on, does it seem like it would be helpful if you hadn't already had an ERG? And two, were there things that we missed with your experience having the ERG for a long time, and sort of that practice journey of like deciding to purchase an ERG, even before that, the practice journey of what patients am I going to help?
Right.
And then if I have these patients that I'm going to help, how do I know it's going to be helpful to my practice? How do I know I have the patient population? I think I want to have the information so I can better take care of patients. But then how do I know it's going to be beneficial for my practice, right? Do I have enough patients where it's going to be worth it for me to use in those clinical situations? And then is it worth it to my practice? And then how do we go about kind of figuring out our processes and our flows within the practice? I think those are the pain points that we were trying to solve with that course. And so you've taken the course, but I don't need to like break down the course or any of the other sorts of things. But that's sort of what the spawn of this is for you to give us perspective of like what was your journey in implementing ERG into your practices, and what was the kind of thought process that you went through. So the first part of this is when you were thinking about the types of patients you wanted to help, not knowing what you know now. But what made you make the decision to say, I need to have this technology in my practice because it will help my patients?
Right. So I would say the initial decision, because we've had the technology now for right about 2 years. We acquired our first Ready Valve device in June of 2023. And one of our practice acquisitions was actually an ophthalmology practice. It was a practice that during 2020, surgery stopped for too long, and they actually went out of business. And so we acquired that location. And
so say that again. That's really interesting to me. So say that point that you made right there.
Yeah. So in 2020, March 2020, right, the world falls to chaos. By the time we reach May 2020, from mid-March 2020, really I think it's probably close to July that most states were actually back in cataract surgery. But when you're a primary ophthalmology practice that generates a large percentage of your revenue from surgery, then they ran out of money. And now we can get into why didn't they use the PPP money, and that had a little bit more to do with just their business acumen and all that. But the reality was they got to the point in late May 2020 where they said, I am closing the door, locking it behind me and walking away. And I had enough of a relationship with them to say, well, let's not do that. Listen, we can figure out a way that we can continue it, under our entity. And so we acquired their practice. It was a 1 MD, 1 OD, and then we had offices in the vicinity. It was actually right in the middle of 2 of our locations, and so we had the coverage to be able to manage it, and I made that my primary clinical location. And so we acquired a lot of pathology. We acquired a large glaucoma practice. We acquired individuals with chronic conditions, diabetes, AMD, that were regularly being seen every 6 months. And so for us at that time, we looked at the ICD-10 codes in our EHR and said, this, we want to deliver the best care possible. What's the newest level of technology that we can provide that's going to give us the best clinical data? And it was a no-brainer. And we can talk about how I think after going through the course, I would probably combine my method and your method together. But initially it was just, we have a ton of pathology. How can we provide the best care possible? And it was a no-brainer for us.
So I think there's a couple things that I wanted to point out. The first one is, again, I warned you that I like to go down these rabbit holes. But what's so interesting to me is not to like belittle the practice that had to sell during 2020. Yeah. What's so interesting to me is you saw an opportunity in a practice that had lots of what I would call pillars, right? So comprehensive care, we can provide all the care that patient needs, whether or not that's an optometrist, ophthalmologist combination, or the optometrist can come in and say, listen, we have patients that are sick that need help. And we can figure out how to care for each of those conditions: macular degeneration, glaucoma, dry eye, etc. Right? binocular vision problems, all these sorts of things. The other thing that's really interesting to me is that while optometry can figure out that model, that we have a really hard time figuring out that model, the surgical practice even was saying, I'm not going to value all that chronic disease management. It's not worth it. And maybe their business model didn't even make it worth it. So the only thing that was worth it for them was cataract surgery, or was the surgical intervention of those conditions, which is so similar actually to what we've done in optometry. Is we've said, many of us, I'm not saying this is you, and I'm not saying this is maybe 10% of the providers, maybe even 15% of the providers, but there's a ton of us in the profession who we will provide those services, those chronic disease services that you're describing, that we'll call pillars of the practice, but they'll provide them sort of begrudgingly, and they're not reliant on them to support the practice. In fact, they're almost detrimental to the practice, where without the sale of a widget, right, glasses or contact lenses, those other things are not sustainable. And so it's so interesting to me that the parallel in ophthalmology is the surgical case is primarily cataract surgery, and now what's probably becoming even more the case is premium cataract surgery, or stenting, or kind of secondary glaucoma procedures during cataract surgery to support the practice. But then they sort of, like all these other things, have become less valuable because they can't either see the volume of patients, or they haven't stratified the testing that they need to take care of the patient appropriately, or they haven't figured out the appropriate billing and coding mechanisms to generate the appropriate revenue from managing those. That they're doing the same thing, just with a different sort of thing that's holding up the practice. That's the first one. The second, so I just think that's a very interesting side note, and that they couldn't also identify, which my guess is that there's probably, if they weren't able to identify what you were able to identify when you came in, it's like, well, maybe there's new technology we can add. Maybe there's new other services that can also, the patients need, primarily they need, but also they generate revenue, whether that's an ERG, or that's a premium contact lens, or a premium other device, or ocular surface disease management, whatever that is. They couldn't figure that out. And I think there's a lot of us in optometry that think, well, ophthalmology is different, right? But you're saying, but what you've just said is that they're really not. They just have a different kind of primary backbone for their cognitive bias, so to speak. Yeah. The second thing that I wanted to point out a little bit, and this is where I want to dive deeper into, is you said you used ICD-10 codes, and I actually love that you did that because it was based on data. So you said, I think that you said was, we have a whole slew of patients with macular disease. We have a whole slew of patients with optic nerve disease. We have a whole slew of patients with other retinal diseases, some known and some unknown or uncertain. And I need data to clarify those disease states, to give me information about function or information more about function where I don't have a definitive diagnosis. So the first thing is, we think that's important. We're going to mine the data of ICD-10 codes that have been used where we think this is going to be applicable. So that was your method, and I actually think that's really good, especially in the practice that you overtook. The reason that I don't advocate for that message that method mainly is because it's messy data. And the reason it's messy is that for most optometrists, I don't know about this ophthalmology practice, but the reason that I don't usually go down that road is because if we use actual billed data, then we can know what were you actually attending to. So again, a behavior that happens in a lot of comprehensive optometry practices, and you may know this, but you may not. This may not be how any of your practices run. From talking to you, my guess is that it's not. I think that you're probably running your practices really well. But in many optometric practices, what happens is we get new devices and we screen patients, right? So we screen an OCT, we screen with a photo, and then we're sort of left with I screen maybe with dark adaptation. And so we're kind of getting this model of screening where we get a lot of information, but then we're uncertain about how to bill it. And so if I'm screening this and I'm like, well, I already got the money from the screening, I'm not going to order it again. I'm kind of uncertain here, so I won't. And so if in those practices, what you'll find if you look at their charts is that they'll put dry eye, AMD, glaucoma, right? They'll list all those things in the chart, or suspects, whatever it is. But then they won't actually actively attend, right? They won't take the time to sit and like, okay, I'm going to see you back for some follow-up evaluation and attend to that one condition or two conditions. They'll just sort of try to cram it all in the comprehensive exam. And so the data never gets billed. And so the reason so then the question is, if we mine ICD data, then we just listed a whole bunch of stuff, but was I actually attending to that condition, or was I finding it and referring it? So that's why I like that data. So the bottom line is, it's not that one is better than the other. It's just that you have to know the advantages or disadvantages of both methods. I like using build data, because I can know if I build this many, I'm likely to be able to pair this new technology with what I've already known build, and then I know we're going to be able to cover our costs on that. So anyway, again, it's not to disagree. It's just that to try to clarify in our minds, like, there are different ways to do it, but I wanted to kind of more clearly state those two different ways.
Yeah, and that was one of the things that really stood out to me in the course, is that, I would kind of define it as that difference between potential and execution, right? You can mine your ICD-10 data and see, okay, this is the potential number of individuals I may have in my practice that would be, this test would be useful for diagnostic purposes. But then if you see that your OCT macula per refraction is at 4%, then obviously you're not capturing on that potential. And so we're in the acquisition space, a lot of times it'd be the same thing as if I said, gosh, if we acquire this practice and keep the same number of patients and we just, increase the revenue per patient to 700, gosh, we'll kill it. But then we look at our own data and we say, oh, but wait, at all of our other practices, we only actually do 350, right? Then there's, we've got to find a way to balance the top end potential and what we actually do on the ground level. And I think probably taking a combination of both gives us that, ceiling to reach for, but then also say, how are we doing actually implementing the testing with our build data, and it gives us some KPIs to watch along the way in terms of what it should be, could be, and what it is. And so I didn't necessarily do it on build, but had I started over, I would have probably said this is our realistic. Now, we've implemented it, gangbuster, just because we're big into functional testing. And you'll love this. In preparation for the talk, I went and ran. So I took.
I was just going to ask. Yeah.
I took our three locations that are our primary, users, or the ones that I go to. In a 12-month period, we ran 1,790 ERGs, and in the same 12-month period, same three locations, for different conditions, because we don't do it for everybody, we did 1,791 visual fields.
Yeah.
So it's just insane that it's almost the exact same number. And again, we're not doing an ERG on everybody with glaucoma, but we are implementing on macular degeneration and diabetics. And so it kind of just shows we just have that so kind of ingrained in our clinical practice that we want structure and function. That organically it was easy to do that. But yeah, the fact that the numbers of visual fields and ERGs were within one over 10,000
so
patients.
Great.
It's wild.
The other place that I did you run your numbers on your number of like Mac OCTs?
I did.
Yeah. What's those numbers? So actually, I was going through this. So I was talking to Gary and Gail actually about this, and then as I was doing my own numbers, I was like, we've been doing really good. Like we recognize the same thing for you. It's like, well, when I say really good, what I mean is I wanted functional data every time I saw structural changes. I wanted that functional data. And in my mind, we had laid out our own protocol, our own existing protocol. And I was like, okay, awesome. We are actually achieving to deliver great patient care. The things that we're doing are aligning with the care we want to provide to patients based on the build data, right? So it's not, again, for the listeners, I'm not saying we're not trying to manufacture clinical care to support build data. We're using build data to show how well we're doing in the clinical care that we believe is important for the patient. But then I started going over my numbers, and I'm really looking at my numbers like, oh, I thought that we were doing this, and we are, but like we are still missing a little bit, because I want to deliver this care, but there's something in our process where I'm missing. So did you look at those numbers? CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today.
Yeah, and so it's so the
you don't have to make an excuse. I'm not asking you to make an excuse.
The retinal OCT it was around 800. But if you combine,
you're probably doing some photos in some cases.
So our 92250 per refraction is like 50%, and that doesn't include our out of pocket. So if you said we're going to lump in structural imaging, and so we'll lump in OCT, nerve OCT, macula, fundus photos that would be billed that we would track, that's around 80% per refraction, right?
Yep.
So and so then that kind of filters back to about 20% either visual field or ERG.
ERG, yeah. So so anyway, I think those are just really interesting pieces because now once you know that, okay, so like that's and that's what Dr. Grant is talking about for the listening audience is, if you haven't heard me talk about this before, you probably have, but what he's talking about is now, if in his protocol he's paired when he wants to have when he has a patient who has diabetic retinopathy, and he's capturing a FAF, for example, to document that and to maybe evaluate for subtle, microaneurysms he otherwise may not be able to see on standard photography or standard ophthalmoscopy. He's also now pairing that with a functional test to see, is this patient's risk greater than what their retinopathy would suggest for progression into vision loss? So he's got a system that is built, and he's intentionally built that system. And now that he's looking at his billed revenue, he can say, am I delivering on that clinical protocol that I want for most patients most of the time? Yes, certain patients have exceptions, but for most patients most of the time. And now he can actually have KPIs and metrics to see if his clinical care is reflecting what his intent is for that clinical care. So you brought up a little bit diabetic retinopathy. Tell me about like why you think this is important in diabetic retinopathy and where that's been beneficial for you from a clinical care standpoint.
So one of the ways that we implemented was we instituted automatic protocols for our staff, and maybe part of the conversation we'll get into just the different ways in which different practices might implement
we'll get into that
from a flow standpoint. But for us, trying to implement it in a busy clinic where each doctor might be 30, 35 patients a day, right? We need to make sure that testing is done on the front end, because it's really difficult to go back into the testing room. Once they reach the exam chair, it's like this is the last stop. We don't go backwards. So we just set up automatic protocols, and actually we perform the DR assessment on the ready valve for everyone with any diagnosis of diabetes. We don't necessarily look for, it has to be diabetic retinopathy first. And the main reason why we do that, one, is because we believe in the clinical relevance of the test and the predictive value of it. But two, if you look at the Burgell study that shows the increase in risk that's associated with an increase in the DR score, which is the single number score assessment that the DR protocol gives you, with each increase in point, it's a 28% increase in risk. And so if we're not establishing an early baseline, we really don't know where we're going. And we're so good at thinking about glaucoma in structure and function. I think all of us in optometry, kind of get that in glaucoma, right? We think of glaucoma as a progressive optic neuropathy. We need to be thinking about diabetes as a progressive retinal pathology, right? If you've had, data as early as 2020 from the American Academy of Ophthalmology would say, if individuals have had diabetes for 11 to 15 years, greater than 50% of those individuals have retinopathy. Once you reach 25 years, 100%, right? Right. It's not a question of if, it's when. And so we need to be intervening as early as possible to establish the risk of needing retinal care. And the best way to do that is structure and function and documenting early and often. So from a diabetic patient perspective, if you have diabetes, you are receiving, at minimum, a DR assessment on the ERG ready valve device once a year. And we can get into the coding and billing nuances of that, but that's how we practice.
Well, I think we'll leave that to the course. Actually, we talk about those sorts of things in the course. I don't think we need to go into the weeds on this, on that part, on that point, because there's a lot of nuance, of course. And but so I think that's all. I mean, you're not going to get pushback from me in terms of the value of what you believe from a clinical standpoint. You've laid it out. There will be people that differ, right? Like there will be people that will listen to this and be like, yeah, I agree with that. That's exactly what I'm going to do. There will be people that's like, nah, I don't think I want to go down that road, but here's where I want to use it. So I think the interesting part to me is 2 points. As a clinician, I take home 2 things. The first one is, the point that you made, and I think it's worth restating, about the increase in points, right? So the DR assessment on the modern ERG from LKC, the Ready Valve, allows us to get a score on the likelihood of progression over time, right? Mm-hmm. So you made the point that if we started out at, let's say, so for those of you who haven't looked at this, at these point systems, let's just say that we start out at a 17.5 score, DR score, which takes into account ERG, it takes into account pupillary function and in both eyes, and so it gives us a score. And you made the point that if we go from 17.5 to next year 18.5 to next year, let's say 22.5, that's going to give you valuable information over time in the absence of changes in retinopathy, correct?
Correct, yeah. So basically a 3-point jump. And again, when we're talking about, for those who are not familiar with the test, we're talking about progression. We're talking about risk of progressing to needing some kind of retinal intervention, whether that's an injection or focal laser or PRP.
To make that point, that patient likely has, if they are at risk for needing those interventions, they're at risk for the things that are threats to vision in diabetes, right? So you're thinking about DME or even CSME, and then neovascular changes, so NVE, NVD, NVI. Yeah, please, go ahead.
Yeah. So if they have a 3-point jump, so let's say 17, 1 year, 20, then that slightly more than doubles their risk. Right, so each individual point jump is around a 28% increase in risk. But another way to think about it, if you go up 3 points, you've doubled your risk. The same study also shows that if you have a 10-point jump, it's a 12x risk. But if you have a 10-point jump, the wheels have fallen off the track.
Yeah, so, they're off.
So I don't know that we don't need to necessarily have a conversation about the risk that's in trouble. But yeah.
So then, let me segue again to kind of another point then. So this is the way I use it clinically in those patients is, all right, let's say I have a patient who has mild retinopathy, and I'm looking at them, they tell me their A1C is, maybe they've had diabetes for 20 years, mild retinopathy, and that's my population. Where I was trained, the wheels were off, right?
Yeah.
Like every single patient who had diabetes, the wheels were off, unfortunately. Yeah. But in my patient population now, that is not the case, right? They're well insured, they're relatively affluent, they take good care of themselves, those sorts of things. I'm not seeing the wheels fall off on most of my patients with diabetes, but I look at a patient with mild retinopathy, and I'm thinking, clinical practice guidelines. If they have no other conditions, like we're not watching them for glaucoma, we're not watching them for macular degeneration, they don't have ocular surface disease. And by the way, that's a really unusual thing, right? For let's say a patient with 20 years of diabetes to not be a glaucoma suspect, or to have macular degeneration, or to have some sort of anterior segment. That's really rare. So just for the listeners' perspective, when people are like, well, I just see patients who have diabetes and they don't have anything else, I'm thinking, well, if they have diabetes, the chances are, if they've had it for long enough, they've got other things. And so, again, that's prevalence data. But let's assume that's the case. And I see them, mild retinopathy, clinical practice guidelines, annual, right? You're looking at them annually. But if I see a DR score of 25, no way. I'm going to see them way more frequently than that, right? Well, maybe not way more frequently, but I'm going to usually cut that in half, right? If our clinical practice guidelines say see them in a year with mild retinopathy, but I have a DR score of 25, 26, I'm seeing that patient every 6 months. Yeah. And if that continues to go up, we may even shorten that. If it's moderate and I'm seeing them every 6 months, I'll probably see them every 4 months or every 3 months, right? So I'm tending to cut that in half. Is that what you're doing clinically?
It is. So I'll make kind of 2 points on that. One, I get asked a lot, does it change your clinical making decision? And you certainly brought up the point of time when it does change our follow-up pattern or recommendations. But I think the part that doesn't get asked enough is, does it influence patient compliance and improve patient outcomes, right? And so if you're able to show a patient that, one, they are demonstrating retinal stress, right, from their vascular condition, or demonstrating progression, right, you can have those conversations about, I know you see the same acuity that you did 6 months ago, but that doesn't mean that there isn't something brewing, right? And there's power in being able to influence our patients' compliance in that way. And I think that that's something that it's hard to measure from a billing and coding standpoint. It's hard to measure even from a device utilization standpoint, but I do think that we see that quite a bit. And then the other just short thing is that if you see a DR score over 26.9, kind of the same researcher, Dr. Brugel, showed that is the number one predictive piece of information that you can obtain for those that might progress to proliferative disease from any stage in non-proliferative disease. So a kind of standalone DR score that's extremely high should be keying you into the likelihood that individual could progress from mild to proliferative within 12 months. So it's there's a lot of different nuances to the value in the score, but again, we use it to motivate patients to take better care of themselves, right? And isn't that what we're supposed to be here for to begin with?
So I love that, and I think your point is absolutely right on. I think it is important for us to consider how a test is going to change our care. The challenge is that a lot of us can go in the wrong direction with that, in that the test should always change my care. And what I mean by that is that, if you only ordered a visual field when you were highly suspicious of glaucomatous loss, then you're always going to find or likely always going to find the patient has lost vision, right? But there's also a ton of value in being able to say, to your point, like, listen, Mrs. Smith, great news. I see a little bit of these changes in the back of your eye. I know your A1C has come down, but I'm also not seeing any functional loss associated with your vision. So keep up the great work, right? Like that's actually, like, to your point, that's really empowering. Or, a patient has a visual field. Well, I did a visual field today. They're a glaucoma patient, and it came back totally clean, right? We're still just pre-parametric loss on our RNFL over time. Maybe we have confirmed progression of RNFL loss, but we're pre-parametric. Was that visual field not worth it? Of course it was worth it, because we know they haven't progressed in their visual field. And so I guess my point in saying that is that sometimes, and the reason I point this out is because I can get lost in that too. It's where I say, is this going to change my clinical decision making? Mm-hmm. Well, it could, right? And if it's normal, that actually could still change my clinical decision making, because I can say, I don't need to do anything further. I don't need to be as firm with my conversations or whatever else. And so my point is that it's just we can get lost in this idea that every single time I do a test, I ought to be influenced in a I need to do something way that's different or that's actionable. I don't know. I think we can get lost in that. I kind of take each potential new adaptation of technology across three filters, right? Does it have the
potential
Yes.
to change my clinical decision making, right? Would it give me, it doesn't have to every time, but does it have the power to do that? The potential to change my clinical decision making? Does it have the potential to confirm my already established treatment protocol and follow-up schedule? And does it have the potential to influence outcomes with better patient compliance? And so if we can say yes, yes, yes to all of that, then we can do the, making sure that we have enough patient volume and diagnoses to support the investment in technology, then to me it's then it's an easy win. It's an easy decision.
So let's just talk. So again, I want to be respectful of your time. You got clinic today. Let's take kind of the last step that I wanted to get before we get your kind of, hey Chris, you need to change this in the course or change that in the course. The kind of processes and protocols that you've set up in your office. So you described in one office, you said, listen, we need to get all the tests we want on that patient that day, obviously that are appropriate to order with medical necessity. We need to do that before the patient gets back to the exam lane. So for me, that's the method in my practice that we typically use. Well, for me, it's that way because I rarely see new patients. My associates will have to take a slightly different path. But, I already know we're managing this patient's slew of other conditions, and I want this information at certain intervals in that patient's care continuum. And unless I see an adjustment or a change, I may want them more frequently, but it's predictable based on clinical practice guidelines what I'm going to likely want in those continuums. And so I will do those tests. Typically, we'll have them ordered before I see them, as long as that's medically appropriate. Mm-hmm. And so that's kind of that's one model that you described. The other model that I think you alluded to was we're so busy in certain locations that we have to have another schedule for testing. Mm-hmm. So that's another model. So tell me about that model.
So we do it a little bit different at various locations. So if you're let's say solo location, one doctor, and you're seeing 75, 80 patients a week, my scheduling theory is that would be better done over 4 days a week than 5, right? And so in our locations that are in that volume, then we have a non-doctor day, once a week. It allows for staff to come up for air a little bit. It allows for opticians to catch up on orders, all of those types of things. But that's not the point of this conversation. So on our...
I agree with you, by the way.
Yeah, on our immediate protocols, you have certain diagnoses, right? If you have diabetes, you're getting the DR assessment. If you have an AMD type macula, you're going to get Flickr 16 or just general vascular conditions. We have lists of diagnoses. The staff know to look at previous diagnoses, get the test first if they have it. And then when it's the return visit, we actually schedule it like you would be getting blood work from your primary care doctor, right? We schedule a separate standalone testing only visit that isn't the same day that you see the doctor, and we try to get that done beforehand because if we have 10 individuals that are coming in on a non-doctor day and because most of those conditions we want more than just the ERG, right? We want structure and functional testing. We want the visual field, we want the ERG, we want some kind of imaging. And that is a tremendous,
takes time.
Yeah, I mean, it's hard to do
exactly.
and do comprehensive meetings. And so for a couple of reasons. One, it streamlines our primary care clinic, just our clinic days when we're there because the testing's already done. The workup side for those patients is pressures, acuities, and then we're right into, the doctor being in there. But also, in a busy clinic, I don't want my entire schedule to be booked out and I can't see new patients, right? I don't want it to be filled with checks and checks and checks and checks and checks. And so if we can streamline those, and some of the time we do testing only that we don't have to see the patient if the tests look good. So it's been a little bit of an evolution.
That would segue into opportunities for telehealth, right? So if tests look good and you just want to discuss, or if it's totally good and you just want to have your staff call them and say tests were great, we didn't do anything. So
we do that.
It's great.
So some locations we have a non-doctor day that we utilize testing only on those, and then on our clinics where our large, ODMD clinic where we see 300 patients a day, it doesn't make, we can't close, clinic care. We just have a dedicated schedule, right? Certain staff are just on testing, just on visual fields and, imaging. And so still done on a different day, right? Still done opposite the comprehensive exam, but all of the tests is done beforehand. So we utilize protocol of, automatic testing based on new patients, or if we didn't know ahead of time that we were going to need certain tests, but then when it's coming back, we operate two different schedules for testing, and so it helps our flow, helps our schedule. Our staff like it better, right? If they're having trouble with the visual field because somebody's terrible fixation losses, right? You don't have 3 people waiting on the visual field room, right? You can feel them steaming outside of the exam room door. So it just has worked well for us in that sense.
So I think the point that I love that you've made, and we make this point in the course as well, is there's probably more than 4, but there's 4 common ways that you can integrate new technology, and specifically an ERG technology, into your practice. And we've sort of outlined 2, and I think the ways that you outlined, Brad, and I've outlined are probably the most common ways. The one that we didn't really do is okay, well, what happens if you're seeing a number of new patients, or how are you going to integrate that in? Is it going to be an intentional follow-up? Is it going to be we're now going to have that patient, the doctor's going to leave and have that patient stay? And there's a couple others that we haven't outlined. The point is not to cover them all extensively here. The point is that if you take that course online, you'll have access to all of those things, and kind of the logic behind why you might want to use one versus the other. But what's so important, and that gets missed so many times, is it's intentional. Again, I don't have a really strong preference for, and I'll tell you why in a second, but for saying do it this way or do it that way, because the reality is not every practice is like mine, and not every practice is like yours. And even within your practice, because so many of those practices function differently, you've had to come up with different ways to deliver the technology and the care that you want to deliver to each patient. And that's what's so important, is that you can consider, how it fits within your practice, and that's what's important. What's important to me is not to make everybody's practice a Chris Wolfe practice or a Brad Grant's practice. But what's important to me is each practice gets to deliver the care that they want to provide to their patients, and in a way that fits with their methodology, that fits with their patient flow, that fits with their practice philosophy, right? So that's why we have to have multiple ways. But that can seem confusing if you haven't really sat down and thought about how it's going to work in your clinic. All right, so the last question, the last point that I want you to make is, where did we go wrong? How could we make the course better? Are there any things that you now know, having had this technology for 2 years in your practice, that we didn't cover in the course that I need to go back and add things to, or other insight that's outside of the kind of scope of the course where you're like, hey, this is what I would do? What do you think, Brad?
So in general, I thought the course was fantastic. I thought it was very comprehensive in terms of covering just protocols and nuts and bolts of the technology as well as billing. I would say I wouldn't even say necessarily changes, just some caveats that I would say.
Yeah, let's do it.
I loved that you said whatever your flow is, don't try to mimic somebody else's flow, integrate it into your flow, with the caveat that if your OCTM per refraction is 2%, let's think about how we change our flow to be a more, to more robust flow from a medical testing standpoint. And the other piece that is not necessarily left out is that I would encourage individuals to invite their staff into the excitement of it, right? And, I know we're talking about objective functional retinophysiology here, and some people are thinking, excitement. You probably see this as well. When the staff get to take a little bit of ownership in terms of not necessarily the decision-making process, but just the care that you provide, right? They love having purpose, right? And so if you can show them, when you have an interesting case, show them, right? Talk about what you found. Talk about how it's different than the care we've ever been able to provide. And, they're going to love that, right? So I think sometimes one of the roadblocks is just individuals feeling like if I add one more thing, my staff is going to be upset with me. Well, don't think about it that way. Think about inviting them into the excitement that you're bringing to the practice. And when they get to participate in that care and feel like they have a meaningful input in that, I don't think it's hard to implement, right? We've had instances where, staff do a confrontation visual field and noticed what, they couldn't put words to it. They've got a hemianopsia. And without coming to find me, they ran a 30-2 and those individuals are in the ER that day. They enjoy that, right? They enjoy those wins from their standpoint. And so if you set up protocols where they have an opportunity for wins, I think you're going to have a really happy staff. I think you're going to have a fulfilled staff, and your integration is going to be so much easier if you invite them in instead of just tell them it's one more thing we're going to do. And so I don't know if that even really fits into the course.
No, it helps a ton. Yeah, that's great.
That's how we try to implement technology because they really do enjoy it.
Yeah. So actually, you were being really kind, but I think there's probably some opportunity to update that course with even just a sort of staff empowerment, staff motivation kind of discussion toward the end that I think absolutely applies to all the things that we use, and specifically an ERG. So, Brad, thanks so much for coming on and doing this. I really appreciate it. It's been a lot of fun.
Yeah, absolutely. I appreciate being here. And like I said, a lot of people don't know that we are recording this sub 7 a.m., but this is optometry today, electrophysiology in the morning.
That's right.